Thanks so much. So what am I going to do first? I'm going to share the screen just as I did before and get into presentation mode, which there. So just as a check, do you all see the screen in presentation mode? And I'm going to stop screen sharing just because on the recording, my not very handsome face ends up blocking out some graphics that would ever be in the top right hand corner. And I worked very hard on all my graphics. So I'm just going to take me out of the picture. Does everybody still see the title slide? And
yeah,
are you good to go?
We're fine. We're good.
Okay, fantastic.
Thank you.
So thank you for the invitation, Francis, to come and speak to the group today, the small but mighty group of us. And here's what I want to go through. I'm going to just pre-apologize for a couple of reasons. One of them is that this is a bit of a Frankendeck that I pulled together from other presentations that I've done on this topic. So there's, I don't mean to sound lazy and like an awful person, but for people that have attended potentially conferences that I presented at or other places where I've given this, spoken on this topic, you might see that I've reused some slides. The other reason I'm pre-apologizing is because I'm a fellow Canadian, and that's, you know, how we do. We apologize quite profusely, and it's one of the funny things about us. Our agenda, I'm going to go through some quick introductions. I'm going to talk about computable care guidelines. That's what CCG stands for. So what is a CCG and why should we care about them? I'm going to get into a bit of a technical description of how you define a computable care guideline and when does it matter that we've defined it in these ways. And then I want to talk a little bit about some emerging new tools that we've got that add significant value. I helped launch a project within WHO a few years ago, and WHO is very much driving the bus on this topic, and they host and are the secretariat for 2 working groups that meet every week and include players like Hamilton Health Sciences, Canada Health Infoways participating in some of the work. Google Health is participating, PATH and US CDC and others are participating in this work. And then we'll talk a little bit about who this can impact and then a Q&A. I'm going to get through the slides as best I can in about 30 or 40 minutes so that we do have some time for questions and answers afterwards. By way of an introduction, Francis gave me a very generous one. I honestly just want you to take in the graphics on the right-hand side of this slide. I was involved domestically in some of the work that was being done in 2006, 7, 8, 9. Immediately following the work in Canada, around the publication of our Blueprint version 2, which was published by Canada Health Infoway in 2006. But I am a delegate of Canada to ISO TC 215, the Technical Committee for Health Informatics, and I was our nominated expert on a project around health enterprise architecture in low resource environments. And that was published in 2009, I think, 2009 or maybe 2010. Since 2010, almost all of the work that I've done has been in low and middle income countries. So this work includes, work in South Africa, in Sub-Saharan Africa, South Africa, Namibia, Kenya, Rwanda, in Ethiopia. I did work in the Middle East. I was an advisor to the Palestinian Ministry of Health. I did a bunch of work in the Asia Pacific region. I was an advisor to the Asian Development Bank for 3 years regarding a malaria elimination project in the Greater Mekong. And then I was actually an advisor to the bank regarding the digital health investments that they would make in the region. I lived in Manila for a while and was one of the authors of their national digital health blueprint for the Philippines. I've advised the national digital health blueprint for Myanmar. I'm presently, like literally today, finishing off some work for Cambodia in that regard. I worked for World Bank in India, for UNICEF in China. And so a lot of the opinions that I have and the biases that I have, to be honest, are very strongly informed by not only what I've done domestically, but very much so by what I've seen and done and the dirty boots experience that I've got in a lot of these places in low and middle income countries. At the top part of the screen, you see WHO, UNICEF, UNOPS, World Bank, Asian Development Bank. The Joint Learning Network is funded by the Rockefeller Foundation. It's the Joint Learning Network for Universal Health Coverage. And then the diagram that's got the little AIDS ribbon on it, that is the US government's PEPFAR program, the President's Emergency Plan for AIDS Relief. It's a $7 billion a year program active in 58 countries. And I was an advisor to them, a senior advisor to them for 8 years. I'm also part of something called Open HIE, which is an open source community around how large digital health sharing infrastructure can be leveraged in these low resource environments to actually improve health. So that actually took longer than I thought it was going to, but that's a bit of an introduction about me, and I think you'll probably help understand where some of my points of view come from, knowing this about me. All right, let's get into what's the topic for today. What are computable care guidelines? So as I said, I've been doing work with WHO on this for a few years now. WHO publishes about 50 normative care guidelines, which means they're the group that convenes experts and comes up with, as the present example is shown on the screen here, comes up with what are the normative care guidelines for providing antenatal care. The notion of a CCG is that we take this narrative text and we express it in a way that it can be understood by, ingested by and understood by a computer. And now that we can do that, we can leverage CCGs to start to increase adherence to care guidelines within a care delivery network. So I'm going to pause on this for a minute because this is really, this is an important point. We've invested in digital health, and in Canada and in other countries, pretty significantly invested in digital health, and it's broadly been taken up. But it largely is leveraged to meter the system. It's used for record keeping, and we don't use it nearly as much for exerting process control on the system. That honestly is the strength that CCGs provide us. It gives us a way to help optimize the amount of care or the proportion of care that is delivered in the green zone. And the green zone is the overlap between what we did do and what we should have done, what was the evidence-based course of care. If we have identified here that if you did do something that you shouldn't have done, that potentially is an error of commission. Those don't happen very often. Clinicians are pretty good at what they do. But one of the challenges, especially if you're not assisted by digital tools, is that your paper records will never jump out and chirp up and say, hey, it's been 10 years since Derek had his tetanus shot, and you should give him one because he goes to a lot of places where it's pretty important that he has it. Those are errors of omission. And there's about a 10-to-1 ratio at least between errors of omission and errors of commission. So a CCG defines three key things: the minimum data set necessary to drive the evidence-based care, the workflow logic, including care escalation and other things like that, that describes the evidence-based care, and then what reportable indicators can be organically and automatically generated from the MDS, from the minimum data set. One of the very important things about computable care guidelines is they're conformance testable. I don't know if anybody is very familiar with some of the legislation we have in Canada and other countries around software as a medical device. If your software is actually informing the course of a subject's care, then it can meet the criteria of a Class 2 medical device. And to be funding eligible here in the province that I'm speaking to you from, here in Ontario, Canada, to be funding eligible, an electronic medical records system in Ontario had to have a Class 2 medical device license. That was one of the requirements to be funding eligible. And that's because they can play an important role in informing the course of care. I said I was going to talk a little bit about how CCGs are defined. I like to refer to myself as a recovering engineer. 40 years ago, I went to engineering school, and I'm in a 12-step program and I'm coming along nicely, but I can't actually claim to be fully recovered. So again, this is a full-on Canadian pre-apology for the fact that some of this might be a little bit on the geeky side. So what are the things that we need to know about providing guideline-based care? Well, there's sort of 4 levels of knowledge representation that CCGs are part of. Level 1, and that's in the first diagram, I showed you the WHO antenatal care guideline. Well, that's a narrative text. You know what, I should be using my own slides here. So that's the first on the level 1, the far left-hand side. In level 2, we take the narrative text and we start to express it in more formal ways. So we might use business process modeling notation. Those are those diagrams, the swim lane diagrams that we pretty regularly see, or decision modeling notation. Those are our truth tables that say this is when a decision should be made because these are the criteria that have fired true. So that's level 2. At level 3, we've now taken these semi-structured artifacts and we've expressed them in FHIR using the Fast Health Information Resources Standard that HL7 has published. So HL7 and IHE have worked together to profile how you would describe this semi-structured content in a way that a computer can understand it. And at level 4, it is then ingested by a digital health solution of some sort, and it's used to operationalize guideline adherent care within the care delivery network. The focus of really what we're going to be talking about today is level 3, how do we describe this using the FHIR artifacts? And level 4, how do we then leverage this to operationalize guideline adherent care during a care encounter? So I'm going to talk about 2 things that are related to each other and importantly related to each other. The first is a process model and the second is a data model for how we would describe computable care guidelines. So this is a description very generically at a very high level of what would happen during a care encounter. And notionally, during any care encounter, I have to identify which Derek are you. I then have to fetch Derek's health story, either from a local database or hopefully from a health information exchange in some sort that's supporting care continuity. Then thing 3 is I want to provide guideline-based care to Derek. And thing 4 is I want to be a good citizen in the care ecosystem, and I want to update the patient's health story, Derek's health story, so that anybody who's seeing Derek subsequently at the same place or in a different place is able to be on the same page regarding what is the health summary for Derek. So I did pre-apologize, and I'm sorry about this, but this is a flow chart that from left to right is showing what are these steps that I should go through to be a good HIE citizen as a digital health solution. So just quickly going through it, I will look up the patient in the electronic medical record system or whatever the local solution is. I will then do a lookup in the client registry, and there's you see ITI 78. That's the IT infrastructure transaction number 78. It's a conformance testable profiled FHIR transaction that you can show up at any one of the events that are held anywhere around the world and say, I do ITI 78, and you can be tested to see if you correctly are doing it. So these things that are shown in red are in fact conformance testable specifications. So the next step here is I do a lookup against a CR, that's a client registry. So if the patient ID is either not found or edits are needed, then I go through the process of entering or updating the patient data. And if that's the case, then I want to update the client registry so that everybody has the updated or the new or the correct data or the original data. If you've never seen Derek before and I'm being onboarded into the client registry, ITI 93 is how that would happen. Then either an existing ID was edited or a new ID was created. If it was just editing the demographic record, then the ID is already known and there might be information about me in the health information exchange. So I would look up the health summary in the shared health record. That's what SHR stands for. And the format of that data is again an international balloted standard called the International Patient Summary. Was developed by the Europeans because of EU regulations that any European should be eligible for care when they're in Europe, but outside their home country. So they developed the International Patient Summary Standard. It's an excellent piece of work. So these are the transactions that you would use to fetch the health summary for Derek. If it's a new idea, if you've just created a demographic record for Derek, then you're not going to find anything about him in the HIE, and so you would add or update information. Any of us that have seen a clinician for the first time knows the drill here. You're just taking a health summary and you're capturing some of that content. Then there's an assessment step. Then now we've got another decision gate. Is this an ad hoc encounter? Did Derek step on a nail and we're just going to do whatever we're going to do to help him feel better and go home? Or is it a guideline-based encounter? Is Derek a diabetic patient and there's a very mature and well understood course of care for how Derek should be looked after during this encounter? If computable care guidelines are available, I go fetch it, and then I go through the process of providing this guideline-based care, and then I update the shared health record with the encounter information, which gives care context. So which providers saw which patient at which place on what day. That's the encounter contextual information. And then the International Patient Summary is updated to reflect what happened during the encounter, and that gets written back to the Health Information Exchange. All right, why did I bore us all by going through all of this detail? I'm going through this detail because this is calling out here where the process model around computable care guidelines is important. It's important because if we can't take the fun out of this, if we can't take some of the variability out of this, we're not going to be able to successfully operationalize guideline-based care at scale. So this process model really does constrain things and make some important simplifying assumptions. Again, you know what, this is too much of an eye chart, but let's just look on the right-hand side, the things that are in red. And we've talked about these already. Identify the patient, retrieve the health summary, retrieve any appropriate care plans for this patient, execute guideline-based care. That's the big number 4 step here. We're going to revisit that. That's why it's in yellow. Update the care plan, update the health summary, and then optionally do indicator reporting. So if there's been if a notifiable event has happened, I might have to update an infectious diseases registry or something. Now, I said we were going to be focusing on the provide guideline-based care. There's an operation in FHIR called a $apply operation. And this $apply operation is how you say if there are instructions that are applicable to follow here, then they will be returned true. They will be part of a set that is returned by executing the $apply on a FHIR server. Okay, that was geeky and long-winded. These are the kinds of things that you can express in a computable care guideline. You can say, when such and such is true, I should provide counseling, and here's what the counseling is that I should provide. When such and such is true, and it could be during every encounter, I should record these observations. So every time I go see the doctor at my age, I get my blood pressure taken, I get weighed, that's never good news. I get my heart rate taken, a number of things, a number of observations are always recorded about me. You can order tests and then conduct the tests as per the order. You can record a diagnosis that might have been informed by those tests. I can order an intervention and then provide the intervention. I can order meds and dispense and administer medications. I can establish monitoring and follow-up, so schedule that there's going to be another visit following up whatever it is that's happened in this encounter, or I can escalate care. I can refer a patient either to augment with some other services that aren't provided at this place, or to take me from primary care up to acute care if things aren't looking good. That's the process model. And I just want you to sort of hold it in mind. This is what's in an international patient summary. It's defined as a composition that includes a bunch of demographic information. If you look in the top right-hand corner here, it's a bunch of demographic information. Who is the subject? Who's the author of this? Who's attesting to it? Who's the custodian of this data? That's typically mandatory. Then there's some required data that the European stipulated must be in every IPS. It's a summary of the meds, allergies and intolerances, and the current problem list. There's a bunch of recommended information that may be there, but it isn't mandatory. What are the immunizations, history of procedures, any information about medical devices? Do I have implants, an implanted pacemaker or something like that? And then diagnostic results, and then optional information around vital signs, past history of illness, am I pregnant or not, social history, that's typically smoking and alcohol consumption, functional status, advanced directives, and then plan of care. Maybe make a mental note around plan of care, since that's where information would be held around what guidelines are applicable for a particular subject of care. This stuff that's on the left-hand side of the screen, honestly, these are all fire resource definitions that have been profiled around the International Patient Summary. And then along the bottom of the screen, we see some icons that indicate the code systems that are leveraged. SNOMED International, I'm sure will be familiar to people. That's one of the comical trademarks owned by the Loink people, which is the little pig. That's Loink codes. ICD-11, those are the International Classification of Diseases codes, version 11, that's published by WHO. ICD-10 is what we're on in Canada, but we'll be moving to ICD-11 in the coming years. And then WHO's ATC, that's Anatomical Therapeutic Chemistry, I think is what C stands for. And these are drug codes, but these are drug codes not for drug products, but for the active ingredients. Very important to know what the active ingredients are, because that's how we do drug-to-drug interactions, for example. And it's also important because if I'm prescribed acetaminophen, for example, well, that's the active ingredient. Nobody cares whether it's a generic or whether it's Tylenol, or that doesn't matter. It doesn't really matter about the packaging either. So ATC codes are an important code set that's part of the International Patient Summary. Okay. Now I have a metaphor, and I'm hoping this is going to become a little bit less geeky. It's a hope. It's a fervent hope on my part. This is going to be a little bit less geeky. So here's my metaphor. The metaphor for a computable care guideline is that it's a folder and it's full of cards. So there would be a separate folder for the diabetes care guideline, and a separate folder for antenatal care, and a separate folder for HIV care, and so on. And inside each of these folders, there would be a card for every recommendation that's part of that normative care guideline. And the cards are the types that I talked about, to gather information, to order medications, to refer. Those are the different card types. Every card will be uniquely identified. And then there's this CAR. For every card, you define the conditions that have to evaluate to true. All of the conditions have to evaluate to true for the card to be played, quote unquote. Well, when a card is played, what is the action that is being recommended? And if that action is taken, what is the result of the action? And these map to different FHIR resource types, plan definitions and activity definitions and so on. But what I really want you to take away here is this metaphor, the idea of a folder full of cards. So looking at antenatal care, for example, I could say that this antenatal care folder can be associated with somebody who has a diagnosis of being currently pregnant. So if a woman is pregnant, the antenatal care folder is applicable for her. And each of the cards, we see there's a number of these cards that have types, and they have globally unique IDs. And one of them says, at each encounter, if I haven't done it yet, provide pregnancy counseling. And the result is a communication resource. At each encounter, if I haven't done it yet, measure the mom's blood pressure. And the result would be blood pressure observations that are recorded as FHIR resources. Same thing for, at each encounter, if it's not done yet, measure the temperature. There's a few things that you always measure at an antenatal care encounter. But then we start to get into some of the interesting things. At the first antenatal care encounter, if I haven't done it yet, conduct a rapid HIV test. And the result there will be a lab result of an observation resource. That's actually part of antenatal care in South Africa. I was an advisor to South Africa when they set up their national norms and standards for digital health. And because of the hugely high prevalence rates of HIV in South Africa, that's part of antenatal care. You always do an HIV test for any pregnant mom. So the next one says, if the blood pressure is higher than the target and they're not presently on blood pressure meds, then prescribe blood pressure meds, and the result will be a medication request resource. So this is just giving you a sense, and it's in pseudocode. Obviously, these aren't FHIR resources that I'm describing here, but this gives you a sense of what cards look like. You could have a card for people who are HIV positive. Same thing. What should you do at every encounter for somebody that's HIV positive? And I'm going to pick out a particular one here. If it's been greater than 6 months since the last viral load test, and there's no active viral load test order, then order a viral load test, and the result will be a service request for the lab test to measure a patient's viral load. So that gives you a sense of what's the deal with folders. So let's step through a scenario. This is MOSA. This is the IPS for MOSA. And MOSA is currently pregnant, and she's HIV positive. There's a bunch of things that have been done because she's pregnant and HIV positive. There was a PMTCT intervention a couple of months ago. And the PMTCT is that she's just put on some antiretroviral medications immediately upon detecting that she's pregnant. There's also certain care path implications to being pregnant while you're HIV positive. There's some blood pressure readings, weights, and heart rates, and other things like that. She was dispensed her antiretroviral medications 2 months ago, but she was only given a 2-month supply 2 months ago. So we can take from this that she probably should be dispensed some more antiretrovirals. So how does this work? Well, the way it works is I take all of the applicable folders for MOSA and I shake out all of the cards. I deduplicate any that appear twice, and I create a stack of cards. That's the way that CCGs work. What folders are applicable, and all the cards and all the folders are put into a single stack. So then I have a process that, and this is a sequence diagram, apologies for that, it's a little geeky again, but SOF is a Smart on FHIR application. Why am I showing this? Well, if I've got an electronic medical record system, without altering its source code, I can leverage the FHIR standard to add the ability for this electronic medical record system to understand and process computable care guidelines by using a Smart on FHIR application that has a CCG engine associated with it. So the steps here is that the IPS is fetched from the EMR. Of course, the EMR might have got it from the Health Information Exchange. I capture user-entered, I should say, content and generate an updated IPS. I submit that to the CCG engine, run $apply, and I get results back that they're returned as a care plan resource, saying these are the things that you should be doing. I process the care plan information that was returned to me. In real time, I render a user interface, and I stay in this loop. You see that it's all in a loop. I stay in this loop until there are no returned care plans when I run the $apply. So now I'm going to start stepping through this. This is the first iteration. On this first iteration, all of these cards fire true because they should happen at every encounter if they're not done yet. All of these cards that fired true are now processed by this Smart on FHIR application that dynamically generates a very rudimentary user interface. Now, the user interface says provide counseling. You can just say, yes, I did that, or provide HIV counseling. Yes, I did that. Or if you're not going to follow the recommended activity or the recommended action, then just say why you're not going to do that. And these are drop-down lists. So either I follow what's recommended or I say why I'm not going to do this. Why is it structured that way? It's structured that way because this is actually affording a clinician a bit of medical legal coverage. This lays down an audit trail of everything that was recommended. And then clinicians are still expected to be making decisions here, but it records that the decision was deliberately made to follow or not follow a recommendation. So if there was a recommendation to give me some drug, and it was blindly followed by the clinician who, it was a recommendation to give me penicillin, but there wasn't in my record that I was allergic to penicillin, but the clinician knew that. They shouldn't give me penicillin because that caused an allergic reaction. There are drop-down codes that the clinician can choose to say, I'm deliberately not going to follow this recommended action, and here's why. But you either get the actions followed or it's not followed, but here's why. And it's never just left as a blank, because if it's just left blank, you don't know whether it was accidentally omitted or intentionally omitted. All right, let's keep stepping through this. So now there's the results of the cards that fired true, the things that were entered into the UI. We now run the $apply again. One card fires true, which says prescribe meds. There's a recommendation to prescribe these meds. I either do it or I say why I'm not going to do it. There's a medication order that's now created, made part of the IPS. I run $apply. No cards fire true this time. And now I exit the loop. Now I'm done. I don't know how many of you have got a programming background, but that was a very inefficient way to go through the process of doing this processing. I'm kind of going through everything every time, but it's patient safe because I never start navigating down some workflow that could unintentionally omit something that I should have done. And this is especially true when we have multiple care guidelines that have to be processed concurrently. So now this is concluded. I'm exited the loop, and I now put the International Patient Summary document back to the EMR, and the EMR, as a good citizen, will update it to the HIE. Now, this has been a bit geeky, and I've been going quickly in the interest of getting to the Q&A, which is probably going to be the most interesting part. But this geeky stuff that we've been going through has huge, huge implications. For this young pregnant woman, this geeky process is progressing her towards, guideline adherent antenatal care, which will be of high quality. And I say that of high quality is something to be underlined, because there was a study done a few years back by the National Institute of Health in the United States that found on a global basis, 8.5 million, between 8.5 million and 12 or 13 million, but the lower bound was 8.5 million people die every year on a global basis from receiving poor quality care. So this is something that's important to start getting right. In 2010, The Lancet published a document series that said if we never invented any new care guidelines, we never did any new innovations in how to care for people, but we just started doing a better job of operationalizing the interventions we have, we would save millions of lives on a global basis. And because I've been doing so much work with WHO, I tend to think of the impact this can have on a global basis. So this geeky little cycle that we've been stepping through is improving MOSA's care. It's improving the guideline adherence of our antenatal care, and at the same time, this is continuing her HIV care journey, which is a lifelong journey. People live with HIV for the rest of their lives now. It's treated, frankly, as a chronic disease. So each guideline-based encounter is now part of a long-running care path, and we're managing this woman's trajectory along that care path. And that's a really big deal. That's an impactful thing. All right, I said that there were some simplifications we had to make. And again, this is going to get a little bit technical. The encounter context has to be established prior to the execution. So that means at the beginning of this encounter, we have to establish who is the provider of care, what facility is this care being provided at, who is the subject of care, obviously, and then what's the date and time stamp. Why do I have to have this context? Well, because there can be scope of practice things. So if I don't know who is providing the care, there are certain cards that don't play unless the scope of practice allows somebody to, for example, order medications. The next simplification, the condition statements have to be defined in terms of, in their entirety, either the International Patient Summary or the Mobile Care Services Discovery Standard that IHE has published. Mobile Care Services Discovery is this cross-referencing specification that cross-references which providers are providing what services at which places under whose auspices. It is a cross-reference spec that takes organizational registries, health worker registries, facility registries, and terminology servers and cross-references them. So all of the condition statements have to leverage those two data standard specifications. The actions have to be defined in terms of the defined card types that I told you about earlier. And all indicators that are defined have to be in terms of the 12 card type results. These are the simplifying assumptions. And if we can't make these assumptions, then we can't use CCGs in this context. And so far in the work that I do, I haven't found a place where CCGs can't be used. But there might be places where they can't be used, anywhere where they can't make these assumptions. All right, where are we with CCGs and where are we heading? Where are we? We have an approachable standards-based way to author CCGs. And some new tooling is being developed to make it easier, but we can use some of the existing FHIR tools to create computable care guidelines. We do have a way that cards can be reused across multiple CCGs. And WHO, so you know, has already authored an antenatal care CCG, an HIV care CCG, an emergency care CCG applicable for children in emergency situations, and an immunization CCG. And a number of, I was a little bit involved in the immunization CCG work, and it was done by Canadian colleagues. We should be very proud of that. And to be honest, right after the project started, there was something added to that scope of work, and it was to do vaccinations against COVID-19. So we have a computable care guideline for treating people with COVID. Multiple CCGs can be reliably and safely executed simultaneously. That's a big deal. And we can leverage the Smart on FHIR specification to put a facade in front of existing electronic medical record solutions or other digital health solutions. Without requiring source code changes in these solutions, we can add computable care guideline processing capability as a facade. This is the sort of crawl, walk, run, except it's bike, car, plane. We're right now in the middle. We have a reusable folder and cards metaphor. We can develop these, we can run them, we can conformance test them, and we can use FHIRpath or clinical quality language, CQL, to define what are the condition statements. Where we want to go with this is that there will be a global library. WHO is going to be the custodian of this library of computable care guidelines that give every country a running start. Now, what's the implication here? Well, this is part of a long-term strategy that WHO has. And step one of that strategy is that they will take all of their 50 or so normative narrative care guidelines, the level 1 guidelines, and publish them as level 3 artifacts, as CCGs. They will do this because the global CCG can then be nationalized by a country to create their nationalized version of the CCGs, and they can then operationalize this within their care delivery network and leverage digital health to start laying down person-centric records that are adherent to the minimum data set specifications and start to improve their guideline adherence within their own care delivery networks. But this is where it starts to really light up some very cool opportunities. If I have these person-centric coded records, I can now de-identify them and start to leverage machine learning or other big data analytic techniques and start to create a continuous quality improvement loop. This now gives a country that is operationalizing computable care guidelines a pathway towards setting up a learning health system. And that's a big deal. The US is investing an astounding amount of money in that. CIHI has that as part of their roadmap and strategy. As I said, I'm doing work with WHO on this. On a global basis, WHO would like to be able to leverage these de-identified data sets to now start to do continuous quality improvement on a global basis so that they can inform the evolution of these computable care guidelines based on what's being determined by their use in various countries. All right, I said that I'm working with WHO. It's a team sport, and there's a lot of people that are working with us. The first thing is to say that two health data standards organizations, HL7 and IHE, are partners in this. It's called a Gemini project, and the two organizations are working together on the CCG initiative. WHO is a very core partner. The US CDC and the US government's PEPFAR program have both provided funding to help make this go forward. Hamilton Health Sciences here in Ontario has been a key co-author of some of the CCG specifications, and they actually, along with Canada Health Infoway, led the development of the immunization CCG that's just now being published. Then there's a whole collection of digital health players, big and small. Many of these are non-government organizations that work in low and middle income countries, but then there's also some commercial organizations and names you might recognize like Allscripts or Google or Smile CDR. These folks are all working together, and this work is all being done by communities, and all of the effort is being open sourced. And that's it. I'm now at the end of my slide deck. So I'll leave the slides available to us, but that's it for me. And I'll turn on my camera so that we can, I'm happy to answer